All right, so good afternoon, everyone. I am Sean Lee, one of the co-leads at HOLA, Heritage for Latino Alliance Employee Resource Group over at Corporate Service Center. And I'd like to thank you all first for joining us today for this Autism Awareness Panel in recognition of Autism Awareness or Acceptance Month. We wanted to bring together a group that not only brings us some of the scientific nature of ASD, autistic syndrome disorder, but also some living experience as well. So, with that, I would first like to share that I also have an 8-year-old son who was diagnosed with autism after he turned 1 years old. So, I share in the experience, and I'm looking forward to some of the information that's going to be shared here today. So, I'm going to pass it to my panelists so they can introduce themselves. Let's first start off with you, Dr. Gorenstein.
Hi, everybody. Thank you for joining us today. My name is Michelle Gorenstein. I am a clinical psychologist, and I'm the director of community outreach at the Seaver Autism Center. So I actually spend most of the time in the community working with UGA Federation agencies, so a lot of the JCCs, Ys in the tri-state area, to help develop more effective social skills programming for children, teens, and adults on the spectrum. I also spent a lot of time talking to parents and providing parents with the supports that they need as well.
And Dr. Treyes?
Hi, everyone. I'm Pilar Treyes. I am a child and adolescent psychiatrist. I work very closely with Michelle at the Seaver Center. I run we have a child psychiatry clinic at the hospital for kids that have autism and other developmental disabilities. And I run that service. And I spend a lot of time trying to bridge kind of advances in the field to community care, and also spend a lot of time with parents and other important stakeholders.
Excellent. And then we have Rita Rodriguez.
Hi, good afternoon, everyone. My name is Rita Rodriguez, and I'm a mom of a 6-year-old boy diagnosed with autism since he has 14 months.
And then we have Kevin.
Hello, everyone. My name is Kevin Kwong. I am a high-functioning autistic and proud student of Queensborough Community College.
Thank you, Kevin. So first off, I'll pass it off to Dr. Gorenstein for a presentation.
So I will say today's presentation is going to try to cover a lot, because I know we have some people in the audience that are just here to learn more. And we also have some family members that might be coming to gain resources. So Dr. Treyes and myself are going to try to kind of cover both aspects, and hopefully everyone will take away something. And I think hearing from Rita and Kevin is I want to give a lot of time for that, because I think that's going to be the most important part of today's discussion. So to just give you a kind of an overview, I'm going to talk about just like the basics of autism. So I know there was already a question about one of the things that we're going to talk about an overview of behavioral and educational interventions for parents that might be going through the system right now, kind of so you can have some familiarity with some of those terms. Dr. Treyes is going to talk about the role of medication. Then we're going to hear from Kevin about his perspective, and from Ms. Rodriguez from her perspective. So when we think about autism spectrum disorders, there was a change several years ago. So clinicians use something called the DSM to make a diagnosis, and it's kind of a checklist of symptoms. And several years ago, there were all these different categories: PDD, autism, Asperger's, and we would give those diagnoses based on kind of this checklist. And what research showed was that clinicians and centers of such as the Seaver Autism Center, Yale, UCLA, were really good at saying whether or not an individual met for kind of autism spectrum, but it was kind of arbitrary how kids were getting these other labels. So one child might get a label of Asperger's in one clinic and might get a label of PDD-NOS in different kind of evidence-based. And that's kind of what led
Dr. Gorenstein, I think you're breaking up a bit.
oh, sorry, can you hear me?
Yeah, I
Yeah,
think
there
your
you go.
Michelle, I think your connection is breaking.
Okay, is it okay now?
It's like in and out.
Yeah.
Um, okay, see, can you hear me okay right now?
Yeah, you're good right now.
Okay, so I'll try to get through it while my connection's good. The idea is that at this point, clinicians should not be using the labels of autism, Asperger's, PDD, and OS. Anybody who's meeting criteria should get the diagnosis of autism spectrum disorders. However, there are a lot of adults who had the label of Asperger prior to this change, and there is a large community of what they refer to themselves as Aspie, and the of changing diagnosis wasn't to take that label away from them. So you will often hear adults say, yes, I have Asperger's. And as a clinician, I would never correct them. But as a clinician, if you are getting a report, it would be a red flag if an evaluator wrote that your child had PDD, NOS, or Asperger's, because as a clinician, those are no longer labels that we are using, but you will still hear them among parents and amongst on the autism spectrum. So just some very basic autism facts. So autism spectrum disorders are a developmental disability, meaning that there's an onset before age 3. So even when we're doing evaluations for adults who have no prior diagnosis, in order to make that diagnosis, we will speak to family members or look at old school reports, because there needs to be some sign that there were some social difficulties or communication difficulties early on. If somebody had no difficulties in childhood and then went to college and started experiencing intense anxiety and had difficulty socializing, they would not meet for autism spectrum disorder, because what we're talking about is a cluster of developmental disabilities. So they might not be noticed early on, but when we talk and ask very, very specific questions, there were some challenges early on. We do know that it's highly heritable. So something that I'm not part of, but Dr. Treyes is the Seaver Autism Center does a lot in terms of understanding genetics of autism. And we do know that there is a high heritability. So the rates among identical twins is higher than the rates of fraternal twins. The current rates are 1 in 59 children. We know that it affects males more than females, but this is an area that we're learning more and more about, as what we're seeing is that females don't always fit in to our diagnostic criteria and are not always picked up on our assessments. So a few years ago, the ratio was 5 to 1. Now it's 4 to 1. My guess is that there are more females that might meet criteria, but aren't getting picked up because of their presentation. And something that I always like to point out, because when autism was first diagnosed, there was a lot of misinformation out there. Almost half of children diagnosed with autism have average or above average IQs. So when we talk about what is autism, we're talking about 2 different kind of domains. One are social and communication deficits, and the other area is restricted interest and repetitive behaviors. And this area also includes sensory issues. And how a clinician makes that a diagnosis is really looking at the child's symptoms as a whole and seeing whether they meet a threshold to get a diagnosis and whether their symptoms are impairing them in any way. So the thing that makes diagnosing autism sometimes tricky is that a lot of these behaviors that we see overlap with a lot of other things. And when we're making a diagnosis, it's really looking at all of the symptoms together to kind of see whether they make this picture. Oh, sorry, went too far. So the idea is we see social communication deficits in kids that have attention issues. We see social communication deficits in kids that have just a language delay. We see some we can see social communication deficits in kids that have anxiety or selective mutism. We might see repetitive behaviors in kids that have OCD. So it's really important then when you are getting a diagnosis or you have concerns that you see somebody who has expertise in this so they can really tease apart if kind of the symptoms that somebody's experiencing is autism or is it something else. So that was kind of a very basic Autism 101. And now I want to just talk about some of the behavioral interventions that if you have a child or know an individual with autism, you might hear about. The evidence-based intervention for autism is applied behavior analysis, ABA. And ABA is often used in a lot of schools in the New York area and around the country. It's a comprehensive treatment approach, and it's designed to increase expected behaviors and decrease unexpected behaviors. And it really focuses on science. So you define what a behavior is, you think about what is happening before a behavior, you think about what happens after the behavior. And it's really built on the idea that if you want something to happen more, you're going to provide a reinforcement for it. And I will say the old school or the traditional ABA is very intense. It's often done in a one-on-one setting, and that's called discrete trial training. And the image on the screen is an example of like a discrete trial where somebody would get a child's attention. The adult would ask a question, the child responds, and then if they got it correct, maybe they would get an M&M. Less and less places are doing discrete trial training. And often there's a stigma associated when somebody says, oh, I'm getting ABA, that they're kind of getting this type of intervention. Yes, some treatment programs include some discrete trial training to learn new skills, but ABA has taken a much more naturalistic approach. So ABA might be reinforcing a child by giving tickles, or if you're teaching a child to request and you put them on a swing, when they make a vocalization, you swing them. So it's a much more naturalistic reinforcement. So some terms that you might hear, discrete trial training, very traditional. Lovaas model is also that very traditional. But now there's more naturalistic ABA treatments. So pivotal response training. The Early Start Denver model is a naturalistic ABA for really young children. Jasper, which was developed out of UCLA, is a very ABA-based model that uses parents to teach joint attention and symbolic play. But when we think about ABA, the thing that all of these have in common is that they're really thinking about a very specific behavior. They're thinking, how can we teach a skill? How can we give a reinforcement that's going to lead to an increase in the behavior we want to see and a decrease in the behavior that we want to extinguish? And I would say a lot of the ABA programs in the tri-state area will use a combination of these. So there'll be parts that use more naturalistic ABA when they're doing classroom activities, and then the child still might get pulled for one-on-one on maybe a skill that they're needing more support. Another kind of evidence-based treatment is the TEACH model. This is developed in North Carolina. This model can be used in combination with ABA. It can be used in combination with almost any other treatment modality. I talk a lot about using these strategies for families at home, but the idea is that you want to use an individual's strengths, so their visual strengths, to help compensate for some things that might be difficult. So if they have difficulty with planning or learning independent skills, the idea is that you can structure the child's environment to help them become more independent. So in the example you see below is a teach classroom where the child sits at a desk. There's a visual schedule for the child with Velcro. There is a box of the activities that the child is expected to do on the left. The child works from left to right. Every day they come in, they know what they're expected to be doing. Another example of using a strategy from Teach would be if you have a classroom, every student is assigned a color, so they just have to learn their color, and their desk, their chair is red, their cubby is red, their materials are always in the red folder, so that way they can go throughout the day, and even if they can't read their name, they can learn, okay, that red folder is mine, this is what I'm supposed to be doing. So it's really a way, and again, I'm overly simplifying. It is a wonderful program, but these are kind of the aspects that are often used in classrooms, I would say, throughout the tri-state area for kids on the spectrum. And those are coming from the Teach model. So just some overviews for social skills programming. What I do is cognitive behavior therapy. So these are thinking about how our thoughts impact our feelings, impact our actions. So some popular CBT social skills programming are the peers, the Seaver Center, skills streaming. These are more for kids that have verbal abilities and are able to kind of engage in a very basic conversation. Social stories were developed from Carol Gray to teach social skills. I will say research has shown that they're less effective at teaching social skills and more effective at helping kids deal with anxiety or manage change. And then for our younger kids or kids with less language, there are behavioral interventions, more based on like ABA principles to help kids learn some of the more basic social skills like reciprocal play, pretend play, things like that. The last thing I'm going to try to do in 2 minutes is just classroom settings. So often when we think of autism, we're seeing young kids coming in, getting evaluations, getting IEPs. And something for those in the tri-state area, again, this is not universal, there are lots of different classroom settings that kids on the spectrum might be. So there are some kids on the spectrum that can be in a general ed setting and don't really need that much support. There are some kids that might be in a general ed setting in their community school and might be getting some supports like speech or counseling. There could be some kids that are in a general ed setting in their community school for part of the day and then attend a kind of self-contained setting for part of the day. So self-contained, when I use that term, it implies all the students have like an IEP or kind of some kind of a learning difference. Then there's also something called the CTT or ICT model. And this is where half of the class would be in a general education, so be neurotypical, and half the class has like a learning difference. And one teacher is a general ed teacher and one teacher is a special ed teacher. And this model really works well for the kids that we see who are able to function academically on grade level, but might need more support in kind of the social area and really benefit from kind of appropriate peer models. And then kind of the most restrictive would be when we start talking about like self-contained schools. So there are wonderful schools that really focus on serving individuals with IEPs, with autism, with intellectual disabilities. And then the most restrictive would be a residential school. So that would be a school where a child would live at and kind of get their academics. The last slide, most of the kids that we see and even adults, no matter what their educational setting, are getting related services. And this is true during school and even through adulthood. And some of the ones that we often see for kids on the spectrum and I keep using the term kids, but I'm talking about teens and adults on the spectrum too, might be speech and language therapy, might be occupational therapy. So occupational therapy can be for fine motor issues, but it can also be for sensory issues, as well as organization skills, time management, money management. Physical therapy is related to gross motor. And then social skills can also be a related service, and that might be through counseling in a group setting or speech and language in a group setting. So I know I just went through a lot of information very quickly. I am going to move on and pass it to Dr. Treyes, and then we'll do all the questions at the end. But if you have a question, you could definitely write it in the chat now if you don't want to forget.
Thanks, Michelle. That was wonderful. So I'm going to speak very, very briefly just to complement what Dr. Gorenstein presented for us about medication treatments used in autism and kind of clinical trials and where research is going and where we're starting to see some signals of things where we can start to find individualized approach to treatment. And then where are some of the limitations that we have. So as Michelle said, we define autism by a set of symptoms. So we say that that is like a behaviorally defined condition. So if we think about other areas of medicine, and we are like thinking of where we were like 150 years ago, if someone would have fever and cough, they would all kind of receive the same treatment. That's like two symptoms, and it would be a specific like syndrome. Over the years, medical advances have allowed us to understand that, you can have cough and fever secondary to having a bacterial infection. You can have cough and fever because you have a viral infection or COVID, but you could also have a neoplasia. You could have so many different things that can present in this way. And really what happens is that now that we can define that, then the treatment for those things are very specific for whatever you have for the underlying biological thing. And one of the things that Michelle mentioned is that these presentations can be very different in very different, children's, individuals, and adults. And that just makes studying and understanding and finding a specific treatments very difficult. So generally, could you go to the next slide? So generally, when we do a study in autism, what you do is you try to choose a population which is as similar as you can. So we try to, for example, say, okay, we are going, and what they would do, if we go by behavior, we're going to say, we're going to have someone that has autism spectrum disorder and also presents with irritability. And then maybe these kids are going to be more similar to each other, and then we'll see if we can find a treatment. So in that sense, we do that, but then if you see in the slides, there's still some kids that really might not fit the figure. So what happens, could you go to the next slide, is that then you give a treatment and you try the medication, and overall, most of the kids don't do well in that specific medication, but you might have kids that do well. So one thing that I sometimes tell parents is that there are only like 2 medications that have an FDA approval for the treatment of symptoms in autism, and that's irritability and kind of aggression. And those medications are Risperidone and Abilify. And those medications are good, and they have they can have a role in treatment, but those medications also might have a kind of worse side effect profile than many of the other medicines we can use. The thing is that in the clinical trials, because the kids are so different, Risperidone and Abilify are the only ones that kind of work across the population. But that doesn't mean that those medications that didn't work across the population might not be useful for specific children. So many times, depending on where you are, you kind of need to think exactly who your child is, what are some of the difficulties they have, and then understand maybe why you're using medications that are off-label and why those medications might be, kind of better for your child in that situation. So although we only have like 2 FDA approved medications, there are many medications that can be used. And that is the reason, because all of the children are so different. Can we go? Yeah. So just to summarize, is that it's important just to remember that if we have more approved treatments, it's also important to remember, I have many parents that come and tell me that child of my friend is doing great on this medicine. And I often find myself telling them, but that's, you know, although the behavior might look different, that is not necessarily a medicine for your child. So every kid is very different. So it's very important to find a physician that you trust, someone with whom you can work. And then just try to understand where things are coming from, because you really need to find individualized treatment. The reason for today that behavioral interventions work so well is that you can tailor to the specific needs of an individual, right? So different people might have different needs, and you can adapt a behavioral intervention. However, you cannot adapt someone's brain to respond to a medicine that it's just the only way you can deliver it. So that is going to be very important to remember. Can you go to the next slide? Yeah. Oh, go back. Thank you. So the other important thing is that today, as you know, the treatment of the core symptoms of autism are medications. Are behavioral interventions, I'm sorry, which is some of the things that Michelle spoke about. However, medicine can have a role in the treatment for autism. And what we do is we use a symptom domain approach. So if you have a kid that has autism and might have aggression or irritability, you may use a medicine to treat that aggression and irritability. And by improving that, then that child will be in a better place to receive behavioral interventions, which can have in turn a huge impact in development. The same happens with sleep. If a kid's not sleeping, obviously whoever has kids here with autism or not knows that then the parent is not sleeping as well. So sleep is huge, and many times kids with autism just do not have regular sleep patterns, and they might be fine during the day, but the parent has a regular sleep pattern and they do need to sleep. So sometimes treating the sleep, it's, you know, it's to keep the child like sleeping at night, and it's also to help the whole family, because mom or dad, they need to be available the following day to be able to deliver those behavioral interventions at work, right? And of course, some kids do need to sleep and they just have issues regulating themselves. You may be able to treat some compulsive behaviors or ADHD symptoms or things like that. And treating those things, if you identify them and the child responds to treatment, can help him be available again to receive these behavioral interventions. And that really can change the course and can cause it kind of amplifies the intervention. That's one thing. I'm just going to mention some of the medicines that we use very briefly. So one family is these ones that we call typical antipsychotics, are the only ones that have FDA approval. As I said, although they work, we reserve them for cases that are more acute, for crisis, because they have kind of a worse side effect profile than some of the other medications that we use. However, some children do beautiful in this. They have no side effects and they need it. But if you are considering medications, and I would encourage you to have a conversation with your doctor, and if the first one that is offered is risperidone, to be why is risperidone and maybe not some of the other medications that might have at least less side effects, and maybe you can postpone or you can prevent using risperidone, which is a medicine that requires blood work. That's another important thing. If your child is on risperidone or a typical antipsychotic, every so often you need to get some blood work and medical monitoring. Can you go to the next slide? Medications for ADHD. This is one thing that is critical, is ADHD, just like autism responds to behavioral interventions, ADHD responds to treatment with medication. So if a child has comorbid ADHD, they are much more likely to do better if they're on medicine. And this is important because kids that have autism and comorbid ADHD are less able to, kind of learn and grow, and they have what we call lower functional or adaptive skills, because they can be very impulsive or have trouble regulating their emotions or sitting still to get interventions. So sometimes by treating the ADHD, these kids can blossom, because then they are available again to receive these interventions and their attention can be focused on the right things. Can we go to the next one? And then we have anti-epileptic drugs, or what we call mood stabilizers, also have a role. Sometimes we use them. This is not the first, line of treatment, but again, they could have a role in treatment, and some, patients kind of end up in this medication. So you sometimes have to keep trying, and that's, I guess, the message as well. Can you go to the next one? And then antidepressants, these are medications that are great and in the general population are used widely. They're very safe in terms of side effects. People can be on them for many, many years. I think if a child with autism or a developmental disability has anxiety and he doesn't have side effects, he probably is going to do well. Part of the problem is that sometimes the medicine that is treating the anxiety might cause more side effects in these children, so they stop working. So we use them. I think if a kid has anxiety, they should always be offered, because if they work, they will work beautifully and the side effect profile is very low. And then if they don't work, well, then they don't work, and then you can move to another family class of medications that maybe will work, but will have some that the risk benefit is different. So finally, the kind of points to take home just to wrap up, and I know I'm kind of going through this fast and just giving a lot of information, but so the treatment foundation is still behavioral and psychosocial treatments. Although there's only like these 2 medications that are FDA approved, there's a lot more. The field is moving towards this place of like where biology defines the type of autism someone has. And as we move in that direction, we will be able to identify specific treatments. So there's already clinical trials on specific causes of autism. All of these are genetically defined. And we're moving in a direction where eventually we will be able to identify those treatments and offer them to the population more broadly, but we are not there yet. On that same line, because we now can define autism with a genetic diagnosis, if you have a family member or autism, getting a genetic diagnosis is key, because it can help identify what type of autism that person has and might help guide treatment. And again, like one issue that we have is that it's such a heterogeneous condition that it's been difficult to identify treatments, because these individuals, they kind of have the same category of symptoms, but they are all very different biologically, and that just affects the way you treat this. Again, we're going to move on, and now I know Kevin is going to talk us a little bit about his own experience. And again, like if you have any questions, please write them in the chat. Thank you.
Hello there, my name's Kevin. I am a high-functioning autistic college student at Queensborough Community College, and I am in my second or third year in college. The accommodations I currently receive at college is a basic calculator, extended time, assistive technology such as a tape recorder. I also get my own accommodation cards when we have tests. This means I have an extra time and a half and a separate place to take my exam. When I'm done with college, I hope to be an artist and animator in the future. The challenges that I have is I'm easily distracted and I procrastinate. I also am fidgety on occasion due to ADHD. I have to attend social skills to navigate the social world. As an ASPE, I find it difficult to read people's expressions and social cues. I am charismatic. I'm a charismatic talker, and I have good memory. I could recall things clearly. I also am very creative. I'm also very creative when it comes to art. To recall things really clearly. I also am an artist.
Great. Thank you, Kevin. And I've had the pleasure of knowing Kevin for, I would say, over 15 years. And I've always been so impressed with his ability to articulate and his insight. So thank you, Kevin, for sharing your experience. And we will probably, I'm sure people will have questions for you. But now I want to turn it over to Ms. Rodriguez.
Hi, how are you? So
Yeah.
Rita is the wonderful mom of Samuel, and I think she will tell you a little bit about her experience, kind of getting the diagnosis and all of the things she's done to empower herself. I have the pleasure to be Samuel's doctor, and just having Rita as really a partner in the treatment, which is really wonderful.
Thank you so much. Thank you, everyone. The first thing that I want to say as my part is all the glory belongs to God, who can give us the strength and to do this journey, because it's really important to understand as a parent how is this works. For mine, my son, he has 6 years old. He's in kindergarten now. He's receiving ABA and all the related services, speech, occupational and physical therapists as well. And thank God we find Dr. Reyes in our journey, because it was so difficult in the beginning, because my son was diagnosed when he has, it wasn't diagnosis. I see some difference in his behaviors. In the beginning, everything was okay, a normal child who was responding, who was with contact, eye contact with you. He was listening, he was happy, he was playing with another kids, but something happened between the 12 and 14 months that he stopped to do the regular things. And I, as a parent, I see that everything was different. For example, when we went to church, he was happy with the music, but he started to cover his ears. And then when I ask his name, when he's calling his name, he doesn't respond to me, he doesn't see me. And then he started to do behaviors like flapping hands, do sounds, different sounds that it was too loud. He was turning around and a fast, smooth, turning. And I say, something happened, something is different now. So we were on Orlando, Florida at that point, and then we come back to New York, and I started to looking for information, and I did my own screen. I found something on internet, and I say, let's see if the thing that I'm seeing is relative with something else. So I told my husband, can you please sit down here with me, and can you see this screen sheet, like to check all those behaviors? So and we started crying, because we see that all that we see in our child is on that screen. So that's that we started. As a parent, I believe the first thing that we can see, that we can do, is to study our child, to see, because he stopped, my son he didn't point in the beginning, he didn't talk, he didn't say anything. The only way that we can find, it was like guessing, asking ourselves, how is it doing now, and how is doing later, and what happened in between. That's the way we started to find the ways to understand him, because he didn't get nothing. He didn't say, I'm hungry. He didn't say, I'm sleepy. He doesn't sleep for the whole night. He got a lot of sensory issues for eating, for taking a bath, for taking haircut, to go out, to feel the sands, to feel the grass, and then in addition, he has a lot of problems that he can say it, as we were working with Dr. Reyes, and then become an aggressive behaviors, because he didn't say how he's feeling. So working with Dr. Reyes, we can it was a long journey to figure it out that something happened internally in medicine with him, like headaches, stomach ache. And finally, we find my son is on medicine by Dr. Reyes in a treatment, and we are finding the way. Now he's more calm. We understand he got some headaches because we try a medicine for headaches because one of those behaviors was he was um moving his head. He was touching his head, but I didn't understand. But one day he was singing the five monkey jumping off on the bed. One fell off and bumped his head. And I realized that something happened with his head. So I said, Dr. Trey, something happened in the head. Because all the doctors, he was on the clinic, he was admitted 3 times for around 10, between 7 to 10 days for aggressive behavior. And we were trying to see what's going on with him, and we had no answer. And Dr. Reyes says, there is something inside him that is bothering him, but they don't realize what it is. And we don't. Well, thank God we found that it was a headache. So he's on medicine for headache, and now he's more happy. And then that's happened also with the stomach. And he started to flapping hands and then hitting his stomach. Sometimes it wasn't the same time. So I said, Dr. Reyes, something happened with the stomach. So we went to the gastro, and we find that he has reflux. So now he's on medicine for reflux. He's getting better. For me, it's understanding and to see the journal day by day. Autism word is so big, but it's just one, our son, our family. So there are different, even they say there are autistic, all of them that are different. For me, just a study and watching my kids, seeing morning, nights, afternoons, day by day, what was the changes, I can understand him better. And for now, if any question, Dr. Reyes.
I think that was wonderful, Rita. Thank you so much for sharing your story. I know you've been through so much in the past few years, and I have to say that you know, we've been able to figure out what was going on with Samuel, but you know, just because she was there, like really trying, and as you know, as parents, I would really encourage you to become like partners in treatment and learning everything you can from every provider. Just ask questions and learn the interventions that the kids get at school. There are interventions that you should also be doing at home. Like, so they are not getting like 40 hours of ABA a week, but like 7 days a week, 24
Exactly.
hours. And yeah, Rita has been, you know, she's the example of someone that has done everything she can to empower herself and help someone.
And I will also, sorry, I was going to say, I will also say, to kind of go along with what she was saying, that I often feel like parents feel like if they go to a doctor, they have to listen to everything the doctor says.
Oh no.
Could be, no, you as parents, and as also individuals on the spectrum, you should feel like your voice matters. As an adult on the spectrum, you are an expert on yourself. As a parent, you are an expert on your child. And if you go to a clinician or a therapist and they are not listening to you, that is a red flag, and you should be finding somebody else.
Yes, it's a teamwork. I think it is a teamwork because they can tell you what they know about the general autistic thing, but you can tell the individual about your child. So it can be 3 different. I know so many people who has autism kids, all right? And I say, oh, they do similar things. Like we say, oh, they do the same, but if you see, they do the same, but in different ways, different forms, different, they express themselves different. For example, someone for another kids flapping hands and do sounds is bad sounds or something happened. For my Samuel, when he does that, when he's really excited, when he's really happy, he's flapping his hands like as fast as you imagine, and he do, he sounds really loud and he's happy. And I say, oh yeah, you are happy and everything is okay. If he's quiet and he's looking that, then something bad happened. As and then he went to the early intervention, and then he went to a preschool. That find this that the really good school. This is important too. The school who wants with parents, because the school that my child has with for a preschool, it was early intervention first, and then from 3 to 5, it was a preschool. And they work with the parents. They do a lot of workshops. They do a lot of things to show the parents how they can work with the kids at home. Because in the school, it's just a little bit of time. The most of the time is at home. So we need to know how to do it. So the school that my Samuel went, they offer a cohort, a course that it calls Grow Your One. Well, they teach you how to be a teacher assistant certified for the New York State Department of Education who works with kids with autism or special needs. And I went there and I did it, and I get my certification because I didn't do it for work. I did it because I need to understand all my families with autism and my son.
Absolutely. And I think the key word in here is acceptance, right? Autism Acceptance Month. One of the big things is just accepting that while it will be a long road and work, it's a beautiful experience because they are unique. They do have gifts, and I can totally sympathize with you, Rita. I remember when my son was at that point of the flapping hands and excited and can barely speak, to the point now where I have to literally tell him, leave me alone. You know what I mean? Like he will sit there and give me an entire story. He will correct me on anything dinosaur wise. I feel like he's gonna be a paleontologist at some point. But to any parents out there, it just you have to do the work. You have to get involved. Everything that Rita said is so on point, and all the information shared by Dr. Gorenstein and Dr. Treyas, and especially Kevin, just being so brave to share his story.
Yes.
It's just really awesome.
And I will say, I mean, I've been working in the field of autism for 20 years now, and I do think there is a shift for neurodiversity and recognizing. I know someone in the chat wrote about the fact that how do we combat societal views about like autism and being intellectually lacking. I would actually just say even individuals on the spectrum who might have a comorbid intellectual disability have skills and have things that they would be good at and should be working and should kind of be part of their community. And I think with the neurodiversity movement is the idea that if we get creative, everybody can have a meaningful life. Everybody could have a job. When you look at the large initiatives happening at like Microsoft, they've eliminated interviews. So they have, again, this is more for individuals who are also gifted academically, but individuals in the spectrum who want a job in like computers and processing, that whole world, can kind of, rather than going on an interview, they get a assignment and they have to complete the assignment. So they're being actually assessed on their work as opposed to their social skills. Because yes, social skills are important and it's what I teach and talk about every day, but there are some jobs that if you have a really unique skill, you might not necessarily need social skills to be a computer programmer, right? Like the ability to code is going to be much more important than your ability to talk to coworkers. So there is a shift. And I also would like to highlight for that in terms of the question regarding societal views. I think having adults like Kevin and their agencies like the Self Advocates of New York do presentations for Fortune 500 companies and talk about kind of the assets of inclusive hiring, can help start changing the mindset. And I was at a lecture yesterday, and even there was a adults or teenager, I should say, talking who is nonverbal, but who is an amazing poet. And he speaks using a keyboard. And so it's often to kind of thinking about the next step from the comment in the chat, there's also this connection between language and intellectual functioning, and there's not always a connection. So there are also people on the spectrum who are nonverbal, who are still taking everything in and have a lot to offer, and it's finding out how they can communicate. Kevin, I see you shaking your head. Are you?
Yes, in fact, I was watching a 60 minutes a 60 minutes episode one night, and they were talking about how they are going to have the autistic community and trial run for jobs. They actually had a 60 minutes episode one night where they had them showing a machine, virtual reality, all these fancy devices.
That is wonderful. There's a term that I like a lot. So we talk about like disability, and I think it's about like different abilities, and I guess also remind ourselves that we talk about like typical or atypical, and nobody wants to be just normal in everything, right? We all want to have some things, you know, these like things that make us different is what makes, you know, life sparkle. All of the tests that we have, they are really, you know, meant to guide us to be able to provide help, but I don't think they should be the one thing that we use to kind of define someone. Nobody wants to be defined that way, but any of those tests, with typical or atypical development, if we want to use those terms, they were meant for people like Dr. Garnstein and me to kind of help us understand and then make educational plans, but they are not the only thing that can define. And they have, you know, they have deficiencies, like Michelle was saying, right? Like you might have someone who is very locked in, but maybe they have a lot of language inside they want to tell us. Like Rita was saying about her son, he was starting to tell us, and he found this amazingly creative way to let us know that he had a headache. And
That's
really
better.
Yes.
In the progress of science, I actually the other day I was watching a video. They actually had they have actually implanted microchips into the brain of a monkey, and they actually had the monkey play Pong using nothing but the microchips within the brain. Think of it, 20 or 10 years from now, we will actually have the FDA will finally approve microchips to be transplanted into our
yeah.
First, we gotta get past the vaccines.
But it is possible, you know. I saw
Definitely.
that video. It's
yeah. No, and the field, there are so many amazing things that are happening to kind of help us, and yeah, we are going in that direction. That is wonderful, Kevin. Thank you.
Okay.
Someone,
so Kevin, I was about to say, Kevin, if you look in the chat, people are saying hi, and people are saying how bright you are.
Thank you. Actually, I'm not bright. It's the men at Oxford University who are pulling this off.
no, but it's amazing that you're watching and looking for it. I think that is really wonderful, Kevin.
Actually, mine actually hangs on the idea of actually solving the whole energy crisis of using the same technology that the military is using, which is radioisotope, and which is using the radioisotope reactors that they're using on the Mars rovers.
And Kevin, I think that actually goes into the question that we just got, saying that there are people that are on the spectrum that are multimillionaires, that are in finances, that I wouldn't say it's because they leave emotions out. I would think that because individuals on the spectrum might see things in a different way, might have these unique skill sets, like as Kevin mentioned, his memory is amazing, or might be attuned to details that we might overlook. So I definitely think as society changes its views, that we will see more individuals on the spectrum kind of have these high power roles, because their thinking is important in terms of.
But I'm just saying.
Kevin, what were you about to say?
I was always just trying to add on to the RTG suggestion, but the only trouble is with something that highly radioactive, you're gonna have to encase it in lead.
That would be a problem.
Yeah, but we're right. You're right. I think, you know, it goes about like building on each other's abilities, right? And we talk about diversity in so many areas of life, and I think this is, you know, autism has shown us that there's like different ways to navigate how we go around the world and how we interact and relate to each other and understand and process things. But that is true for so many things, right? That's true for cultures. That's true for even the way you speak and languages. So I think it's so important to just grasp those like different abilities or that diversity and embrace it in a way, in a positive way.
Yes.
And
Definitely.
someone asked about genetics, if you can go to your primary care doctor and get genetics. So yes, so if you have a child with autism, or you are an individual with autism, you can go to a primary care doctor, and they will do at least the first tier of genetic testing is covered by almost all insurances.
Thank you so much. So I know we're at like 2 minutes. I don't want to pass without thanking Dr. Gorenstein, Dr. Reyes, Rita, Kevin so much. And before we leave, Kevin, you have to show us one of your illustrations. You promised me yesterday. Let's see it.
Of course, you know, I actually have a whole story. Actually, I have a whole story that I'm writing about animal people. It's about like a more so a nostalgia trip for an age.
You may have to take down the background so we can see it.
As I was saying, the whole actually I'm also a bit of a story writer myself. I actually like writing these fun little stories about nostalgia, to say the least. It's about character. I mean, it's animal characters, to say the least.
Oh my God,
Oh
that's
my
amazing.
goodness, how
Very good.
detailed.
And Kevin, can I share what you used to draw when you were younger? Because
Wow, that is amazing. I love that. That's so cool.
so even when
Actually-
Kevin was younger, he would draw like the trains.
Actually, I still do draw trains. Let me see if I have. Let me get the file that I have. I have a whole filing cabinet of this.
But as you can see, he's kind of found a way to kind of hone in on his talent, and hopefully will make a career of it.
Absolutely.
Wow.
And I think the greatest part of this panel is having someone from the community to speak on their behalf. Of there's so many panels where that doesn't happen. And as we look at diversity in a whole universe, having people who are representatives of that diversity within those conversations are so important, because awareness helps our society change the structure to fit the people versus changing the people to fit society, because society needs a lot of work in itself. And the last thing I'll offer is a little joke that me and my son have. Autistic is artistic with an accent, and he actually loves that. So I just share it with anyone out there. Thank you so much. I know if you have to drop off, I totally understand. We're gonna wait.
There we go.
Kevin.
Here's one. Yeah. Would you like to compare with the one from age ago, please?
Wait, Kevin, can you just show it?
This is the recent one I did.
Oh, wow.
It's really detailed. Here's another one.
So you've gotten a lot more detailed.
This is my favorite one I did.
Oh,
really,
amazing.
Wow, that's insane.
and a confrontation's going on. You could actually see.
See, yeah.
Kevin, when I hit the lotto, I'm gonna call you to design my house, okay?
I'm just waiting for Lucasfilm to pick me up.
All right, perfect. Listen, thank you everybody so much. I can't thank you all enough, all the panelists, everyone that attended. And next week, April 20th, HOLA ERG is having a financial literacy event. Make sure that you register for that. That is April 20th at 12:30. Thank you all. Have a great day.
Bye.
Thank you. Thank you,
Bye.
everybody.
Thank you, everyone.